Oh, it's not doing that. We're already. Did you give out work? I mean, I didn't. It's in the. No, we're not doing them anymore. Oh, we did one. Do you know what I mean? Yeah, we're good. They're done.
Yeah,
They're not helpful, sorry.
yeah,
Oh, yeah, I really studied them. Yeah.
yeah. We done it out for books.
Thank you, Jesus.
I don't even know if I can get it, Dan, my work.
Or having to bring copies.
Sorry, Dan. I can give them all
Point,
to
we're
you.
just getting across the finish line.
It'll just be a packet.
She doesn't want to. She'll watch the lecture later.
So watch it at home with some popcorn.
Yeah.
What is that? All right, renal transplants. So they've become the gold standard of treatment in patients with end-stage renal disease. We have had a lot of advancements in organ procurement, matching, surgical technique, immunosuppressant therapy treatments, that have all improved patient survival and quality of life. So estimated life expectancy, 15 to 20 years, in living related donors, and then about 7 to 10 years, if that kidney comes from a deceased donor. So if you get a kidney from a living, close family member, that's a good match. That kidney has much more longevity than if it comes from a deceased donor. So this is just showing some of the pre-transplant workups that they do. So the antigen that they look at is this human leukocyte antigen, in terms of matching. Then they have to do a history, physical exam, lab tests. When you do find a match, if it's from that living donor, they're gonna perform an ultrasound. Well, regardless if it's coming from a living or a deceased donor, they evaluate the living donor for congenital anomalies to exclude any underlying pathologies. When they do these workups, oftentimes they prefer to do a CT or an MRA, but you could be called upon for ultrasound to do an ultrasound for organ procurement. So renal allografts. We'll talk a little bit about the different types of allografts or types of transplants, where these transplants are placed, the ultrasound evaluation when we're assessing a renal transplant, and then transplant complications. So when we're talking about transplants, the left kidney is preferred because the harvesting vein is longer, so that left renal vein is longer, which gives them a longer segment to work with. So when it's harvested, if it's harvested from a living donor, it could come from someone that's related or unrelated. A cadaveric donor is from someone who's essentially, brain dead. There's no brain activity, but the body is still alive, the heart's still pumping, blood's still pumping. So in terms of where they place renal transplants, have you guys actually seen one or?
Yeah.
Common, fairly common, kind of common.
Everybody's got renal failure in Delaware.
So where's it placed? Where do
The
you see it?
abdomen.
Yep, like
On
pelvis,
the right
pelvis,
side.
yep,
Yeah.
so it's placed in the extraperitoneal space in the right or left iliac fossa. So more often than not, they prefer the right iliac fossa. But they can place in the left iliac fossa. I've seen patients that have had, transplant, right iliac fossa, that one fails for whatever reason, or, that lived its expectancy. They get a second transplant, they're blessed enough to get that second transplant, then it's on the other side. So you do have to check both sides. You can typically see a surgical incision or scar in that area. If you don't see a scar visible, if the patient's really thin, you might even see something protruding a little bit because it's very close to the surface. they also have to create now a connection to that bladder. So there's an allograft ureter that's tunneled to the dome of the bladder. So, you know, if you do or are asked to image imaging the bladder is part of the protocol as well. But if you had to like assess for jets, you're not gonna really be able to assess for jets with the transplant kidney because of where that ureter attachment is. In terms of the artery connection, there's a couple of different methods that are utilized when attaching that main renal artery to the recipient's iliac artery. They have either an end to side, end to end, or using a Correll's patch. So we'll see in a moment what all those three things are. So we have arterial flow getting to that transplant kidney. We also now need that venous drainage. So we have the main renal vein that connects in a side to end fashion with the recipient's external iliac vein. And then just something to note, whenever a patient gets a renal transplant, the native kidneys, they leave them in place. So those native kidneys become very, very atrophic, very, very small, very echogenic. Sometimes you don't even see them anymore. Particularly if someone's had long-standing renal disease, you know, they've been on dialysis for a while, then they finally receive that transplant. Those kidneys are probably little raisins at that point. They're so shriveled up, like, you know, we're talking like 2 to 3 centimeters even, that small, you know, teeny. So this is a nice picture just showing a diagram transplants in the right lower quadrant in that iliac fossa. You have your connections, your arterial connection, your venous connection, your drainage, and then the ureter connecting to the dome of the bladder. So in this connection, this arterial connection, this would be an end to end. So that the end of the main renal artery is attaching to the end of the internal iliac artery on the right side. Then we said the renal vein is an end to side. So the end of that main renal vein is attaching to the side of the external iliac vein. So urinary drainage is created via ureteroneocystectomy, whereby the ureter is tunneled into the dome of the bladder, resulting in an orifice superior to the native uretrovesicular junction, the UVJ. So this was the 3 connections when we're talking about that renal artery. So we said we have an end to side, end to end, and then a Correll's patch. So end to side, it's the end of that. So the end of the it's the end of the main renal artery attaches to the side of the external iliac artery. So this is probably one of the most common presentations that you guys are going to encounter, with that main renal artery connecting to the external iliac artery. So this is commonly seen when it's a living donor that kidney is coming from. Less common would be an end to end. So in this case, that the end of that main renal artery connects to the end of the patient's or recipient's internal iliac artery. So this could be possibly if someone's got maybe aortoiliac disease, there's a lot of calcifications, stenotic area in there. So there's poor blood flow getting down that maybe external iliac artery, but their internal iliac artery is okay. So maybe they have a stenosis somewhere up here. They may elect to attach it to that internal iliac artery because you're getting somewhat better blood supply. You could even wind up with some retrograde flow. So internal iliac artery, so more likely, so they can connect that internal iliac artery, but unfortunately with this connection, it's more likely to become stenotic later on down the road or even thrombosed. And then another option is this Correll's patch. So I have a full description of Correll's patch here. So this is the most common surgical anastomosis in a deceased donor patient, where they actually remove a portion of the aorta along with that main renal artery. So you have a nice wide opening that's then surgically attached to the external iliac artery. So most common surgical anastomosis performed in a deceased donor patient. So the curl patch is a small circumferential rim of the aortic wall surrounding the origin of the donor's main renal artery. This again allows for a larger connection, less potential for stenosis or injury to develop, and it's less likely to stenose. So that's Carell's patch. Steve Carell's patch. So this can only be done from a deceased donor because with that main renal artery, they take a little bit of that aorta with it to make a nice big opening. Ultrasound evaluation. So we use grayscale, pulse wave, color Doppler. We can use a relatively high frequency transducer because they are fairly superficial. I mean, I've even sometimes have grabbed a linear probe when I want to get a really good look at a transplant kidney. So that's even a possibility or an option. So with this, we need to do a baseline first. This should be conducted within the first 2 days after surgery. And then this becomes the standard for future comparison. Then they do a follow-up ultrasound 1 to 2 weeks later, then 3 months later. Evaluation should include assessing the renal parenchyma, the tissue. So, you know, that's things like the homogeneity of it, the kidney size, assessing the collecting system for signs of, you know, hydronephrosis or obstruction, assessing the ureter, the bladder, the surrounding bed, which the transplant kidney is lying in, looking for maybe any signs of fluid collection, hematoma, seroma, maybe potential abscess formation. And then we assess the renal vasculature. So we're going to assess the main renal artery going all the way out from, you know, the anastomosis. We also have to assess the inflow artery. So the external iliac, the one that's bringing the blood flow to the actual kidney itself. And then we also have to do the intrarenal vessels. So, you know, sampling the vessels at upper pole, mid pole, lower pole to get a general idea how that kidney is being perfused in all sections. So it's very similar to your standard renal artery Doppler protocol. We're just replacing the aorta velocity and measurements with an external iliac artery velocity and measurements. So again, we're going to study the entire length of that main renal artery. We're also going to assess the main renal vein as well, looking for any signs of thrombosis. We want to assess their connection sites, the anastomosis sites, and the recipient iliac vessels. So, like I said, we're going to assess the iliac artery to measure velocities and determine, you know, that there's adequate blood flow getting to that transplant kidney. We're also going to look at that iliac vein to ensure that there's no thrombosis or obstruction that could potentially be blocking the drainage of that transplant kidney as well. Transplanted main renal artery and intrarenal arteries exhibit low resistant flow. So the main renal artery velocity may be elevated. So with transplants, we have a higher range. So that normal range could be anywhere between 200 to 250 centimeters per second. And resistive indices should be less than 0.7. External iliac should demonstrate high resistant waveform. And then we should also evaluate the patency of that main renal vein as well. In terms of the main renal vein, typically you're not assessing that vein in its entirety. You're just kind of putting color on, making sure that you can visualize it, and then Doppler it to show that there's flow within it. So renal transplant versus doing a native kidney ultrasound. So because those transplants are much closer to the surface, you get much clearer anatomical details. when you're assessing the transplant kidney. The cortex of a transplant kidney is typically more echogenic. There's more cortomedullary differentiation, so that cortomedullary differentiation is more pronounced. Allografts are usually enlarged. So there's renal hypertrophy with this transplant kidney. So if you guys have ever seen them, they're usually gonna measure 13 centimeters, sometimes even bigger. I mean, I think I've gotten as big as almost 16 centimeters. This thing is huge. But if you think about it, this is the only kidney that's functioning in this patient, so it's working hard. And it's gonna expand in size because it's doing the work for two kidneys essentially. So yeah, so you're gonna see, so don't be alarmed, you know, when you put that probe down and you see this big, huge kidney, that's normal. They become hypertrophied. Another thing that's usually fairly common is a little bit of mild hydronephrosis, or maybe a little dilatation of the renal pelvis, a little pelvilectasis, you know, typically a common finding. But if you see anything that's, you know, more significant than mild hydronephrosis, you know, then that could potentially be of concern. Again, we see some moderate echogenicity, so that cortex typically becomes a little bit more echogenic. But we should have nice low resistant flow within the kidney and the main renal arteries. So these are some renal transplants from 3 different patients. So the first one is just demonstrating kind of like your first shot where you would see the external iliac arteries coming from, you know, the top, right side, right corner of the screen, and then running down. And then you also see that, external iliac vein as well. So this would be the image that you try and obtain to be able to Doppler that, external iliac artery. You want to make sure that there's, again, adequate blood supply getting to that kidney. Then you want to Doppler that, proximal anastomosis connection site. And then follow that main renal artery all the way out towards the hilum of the kidney.
Yeah, another question.
Yeah.
So you said the external iliac artery should still be high resistance, even though that blood flow is going to the kidney.
Some of it is going to the kidney, yes, but majority of it is still destined for the legs. So it's still going to be high resistant to external iliac, yes. And just some more pictures showing a normal renal transplant. In this case, they had a ureteral stent. So you can see the stent in the ureter in this case, so that could be, you know, sometimes they elect to place that to promote healing without stricture. The middle picture, they're Dopplering the renal vein. So renal vein should have some pulsatility to it. That's showing a nice patent renal vein. So these transplant waveforms should look very similar to your native, you know, kidney transplant, kidney waveforms for your native kidneys if you have nice, healthy native kidneys. So when we get into the Doppler assessment, you know, you're gonna be assessing your peak systolic velocities, you're gonna be assessing your resistive indices. Some labs, again, will have you measure that acceleration time or calculate that acceleration index. There's not gonna be another parameter that's used to determine, you know, if there's tardive Parker's waveforms or if there's disease within the kidneys. But really, the most important thing is that resistive indice. That's kind of your, like I said, canary in the coal mine, kind of gives us a precursor to that. There could be something impending or coming up, or that this kidney is under some sort of stress. So causes of renal transplant dysfunction. So this is just a list of a couple of things. We have acute tubular necrosis, ATN. Rejection, we're gonna discuss rejection. There's a couple different stages or phases of rejection. So there could be hyperacute, acute, or chronic rejection. Drug toxicity could lead to renal graft failure. There could be vascular complications. There might be fluid collections that develop, infection in neoplasm, and then ureteral obstructions. So in terms of prevalence, the top three are your three main ones. So I would star those being your three most common: acute tubular necrosis, rejection, and then drug toxicity are your three most common causes. Clinical presentation, if someone is having complications with their transplant, could be signs of renal failure. So their BUN creatinine levels all of a sudden are starting to spike up, elevated BUN, elevated creatinine levels. They may present with a low-grade fever, so if there's some sort of infection going on, maybe they have a bladder infection that's now spread to the kidney. When they run labs, they might demonstrate elevated white blood cell count, indicating that infection. Or pain, if they're having any sort of pain over that incision or over that transplant kidney. So things similar to a patient who's got, kidney stones or a kidney infection that might have flank pain. This person might have lower pelvic pain where that transplant is. Then ultrasound is becoming an imaging modality of choice for evaluation in the immediate and post-op and long-term complications, and assessment of the kidneys. Ultrasound also helps in guiding interventional diagnostic and therapeutic procedures. You can also be used to perform renal biopsies, which are a gold standard for diagnosing the underlying cause of graft failure. All right, so acute tubular necrosis. So this is related to the deposit of cellular debris within the renal collecting tubules that causes damage to the tubules. So with acute tubular necrosis, the cause of this is due to ischemia from the donor before transplantation. So this kidney, for whatever reason, was cut off from blood supply for extended period of time. And that allowed her for this cellular debris to get deposited within the renal collecting tubules. So think of it as like gunk or dead cells essentially being deposited within these collecting tubules, and then it starts to decay and break down, and that's what causes eventual the graft failure. So it's the most common cause of graft dysfunction in the immediate post-operative period and can affect anywhere between 10 and 30% of transplant patients. It's more common in the deceased donor patients than it is in the living donor patients. Typically, if you think about it, because of that prolonged ischemia time to that kidney, so it's a matter of time they want to race to get that kidney from that deceased donor directly into that living donor. Unfortunately, like that deceased donor might be, in a completely another hospital further away. And they might be that transport time where they're trying to get it to that living recipient or into the recipient, that extended period of time, leads to this acute tubular necrosis, that extended period of time where that kidney wasn't being perfused. So again, risk factors for acute tubular necrosis: prolonged ischemic time of greater than 24 hours. So if it was a longer than 24 hours where this kidney wasn't getting that adequate blood supply, significantly increases the risk for tubular necrosis. If there was hypotension involved, so maybe that deceased donor had very low blood pressures, and there wasn't adequate blood flow perfusing that kidney, that could lead to acute tubular necrosis. Again, if there's excessive blood loss, another condition that could create ischemia. So there was poor, again, excessive blood loss during that transplantation surgery. That kidney wasn't getting an adequate blood supply and leading to cellular death and debris being deposited. Prolonged illness or intensive care stay, for the donor. Again, or from a donor that had a non-heart beating donor. So if that donor went into cardiac arrest, the heart wasn't beating for a period of time, wasn't perfusing the kidney, and led to ischemia of that kidney. So how do we see, or how can we tell if, again, a patient is experiencing or is, if there is acute tubular necrosis? One of the things we look for, again, is that increase in resistive indices now. So that's one of the ways acute tubular necrosis starts to manifest itself, is increased RIs, so decreased diastolic flow or increased resistive indices. So that's essentially saying the same thing. So the higher that resistive indice, the worse the acute tubular necrosis. Yeah.
Sorry, another question. I forget if it was the liver, but what were you talking about that right after the transplant, it's high resistance and then it goes down?
Yeah, that was the liver transplant when we're the hepatic artery and the liver transplant.
Okay.
Yeah,
So
so,
hepatic artery at first is high resistance and then it goes back.
and then becomes low.
But
This should always be low resistant,
Okay.
like from the moment they transplant the kidney. Yeah, you should always have low resistant.
All right.
So this was an example of acute tubular necrosis. So this kidney came from a deceased donor. Patient demonstrated decreased urine output, increasing creatinine levels. No hydronephrosis was found. When they Dopplered that segmental artery and the arcuate artery in B, high resistant waveforms were seen. So this was segmental artery, arcuate artery. So essentially, there's no diastolic flow in this at all. I don't know why they measured end diastolic with 5, but maybe. But these are very high resistant waveforms. 3 weeks later, they improved, and you saw the resistive indices getting closer to that normal range. So thankfully, this kidney was able to heal itself. Then hyperacute rejection. So now getting into another most common cause of kidney failure. So with rejection, it can be broken down based on how close it is to that post-surgical period. So hyperacute rejection is something that's going to happen in that immediate post-surgical period, less than 24 hours, after surgery. So this is, they've had their transplant, they're in the recovery area. This hyperacute rejection is going to happen within that first day, within the first 24 hours. So it's usually in the recovery room. This is also a very extremely rare occurrence. And it's usually due to histocompatibility. But because we have very good testing for compatibility now, this becomes very, very rare. So with this hyperacute rejection, we see very elevated resistive indices. So that diastolic flow may be absent. And we might even get to the point where we see reverse diastolic flow. So if we get a little bit later into that postoperative period, so within 1 to 3 weeks to months after their transplantation, this falls under acute rejection. So 20 to 40% of all renal transplants This represents. With this, patients will appear asymptomatic, or they can present with flu-like symptoms, graft tenderness, low-grade fever with deteriorating renal function, a rapid rise in creatinine levels. Some signs might be swelling of the graft itself, again, increased RIs, so that's something that you're gonna see common in all of these, so increased resistive indices, and then reduced parenchymal flow. So similar to a patient who's got medical renal disease, when we put color flow on that kidney, if we see reduced flow in the cortex of that kidney, that could start indicating the presence of acute rejection. In order to make the diagnosis of acute rejection, we need to perform a biopsy of this kidney and test the kidney. With acute rejection, sometimes it can be treated with steroids or immunosuppressant medication. So this is also an indicator of future transplant failures as well. So if they've had acute rejection in the past, they're more likely to have acute rejection in the future as well, unfortunately. So sonographic characteristics, acute rejection, I think there's a large swollen kidney. This is pointing to some free fluid actually outside that kidney as well. So that's something you might see. And then after 3 months from surgery, would be considered chronic rejection. So if this patient starts developing these symptoms after 3 months, 3 months after surgery. This is considered chronic rejection. So this may lead eventually to renal failure. The most common risk factor would be a previous episode of acute rejection.
Kind of sounds, okay, kind of a stupid question, but if they do have rejection and you said they can use like steroids, would they try to take it back out? What would they do? Just put you on like another donor list to try to, like, what do you do at that point?
If you're in
Like, oh,
acute
crap,
rejection?
not working.
Yeah, so if you're in acute rejection, they're gonna do everything they can to try and save this transplant kidney.
Okay,
If it does fail and dies, you'll have to go back on dialysis.
and then
they
on the
would
donor
just,
list, or
yeah.
start all
have it
over.
Start all over. Yeah.
Okay,
And they leave this kidney in there.
I kind of think, oh,
Yeah, they don't even remove
okay.
it.
So now you have the real kidney, you have the transplant kidney, and then would you have another one on the other
On
side?
the other side, yeah.
Okay, and then what?
If that one fails also,
Well, shit out of luck.
you need a better surgeon or doctor, yeah. I don't know, they would have to really work you up to see is why these kidney transplants keep
Yeah.
failing. Like,
Okay.
is it your body that's attacking it? Maybe they need some sort of different immunosuppressant medication. Like, why does it keep failing? You know, if we've matched you up properly, it should take.
Yeah.
Maybe it's a surgical technique thing, maybe, who knows?
20 to 40% for, what was it? Acute?
Acute rejection.
That's a lot.
It's a lot, it could be.
Oh, okay.
So with chronic rejection, so now this is opposite in appearance of the acute rejections. With chronic, the kidney is actually decreased in length now, so it's starting to shrivel up. It's starting to have the appearance of, you know, chronic medical renal disease where we get the cortical thinning. It becomes more apogenic, and again, we also have those increased resistive indices. So acute rejection, the kidney is actually shrinking in size. It's decreased in length. Whereas with acute rejection, it's large and it's swollen. So acute rejection, large swollen kidney. Chronic rejection, it's echogenic, decreased in length. That thinning of the cortex.
So kind of like pancreas. That'd be the project.
Yes, acute and chronic pancreatitis, yeah. Similar. With that, you're also gonna see very diminished flow, particularly in that cortex, like I said. So a transplant kidney should light up with color. So if you just see some color just relegated to that, central part of the kidneys, just the medulla, then that's not good. You wanna see flow perfusing throughout the entire kidney. So, something like these guys, where you see flow all the way out to the cortex, all the way out. You want that kidney to really light up with color. So here's a picture during transplant rejection. So you can see the transplant. And you can see the liver over there in that picture as well. So this transplant is so large and swollen that it's going all the way up, actually touching that inferior portion of the liver there. So this would be an example of acute rejection. The kidney is swollen, central sinuses are poorly visualized, pyramids are prominent. Take a little photo memory snap of this picture. I think it might show up on the final.
Yeah.
Acute rejection.
What's slide number?
What is this, 25?
Thank you.
Acute rejection. And another example just of prominent pyramids against that echogenic cortex, elevated RIs. So again, with transplant rejection, we can see those elevated resistive indices. So again, this has an RI of 1. There's no diastolic flow. So left abnormally high resistance from mid-pole segmental artery, absent diastolic flow. The right is severe rejection. So it's become, the RI has become so high, it's actually becoming triphasic now. So we even get a little bit of momentary flow reversal during diastole. Then we said the third most common cause of renal transplant failure is drug toxicity. So this could be actually due to some of the immunosuppressive medications that are administered to these patients that can actually cause damage to the kidney. So unfortunately, these medications or these immunosuppressive agents are actually nephrotoxic. And they can lead to renovascular constriction and interstitial fibrosis, so they can actually damage the kidney themselves. So they need them in order to prevent rejection, but they can also be potentially nephrotoxic and damage the kidney. So in that case, it might be a matter of trying to find some different immunosuppressant, adjust the dosages so that it's not, as damaging to the kidney, try and get by on just that bare minimum amount. So it's kind of a delicate balance. Again, this is doctor stuff, nephrologist stuff, way above me, but just understand that, drug toxicity is the third most common. And it's related to a lot of these immunosuppressant agents that are actually nephrotoxic. There's also a virus, polyomavirus, that can lead to renopathy. So differentiation of chronic rejection from drug toxicity. This would also require a biopsy and careful correlation with serum drug levels. So that's what they had to do with Terry back in the fall when she had renal failure. They actually did a renal biopsy to try and figure out what was the cause of her renal failure. Why did she enter into acute renal failure? And then vascular complications. So this is where, we come in also with our ultrasound when we assess the vasculature. So vascular exam of renal transplants is, to trace, the transplant vessels in their entirety. So vascular complications occur in less than 10% of, transplant recipients. And this is a treatable cause of graft dysfunction. So if we know what the issue is, with the vascularity, we could potentially, stent it open. If it's thrombosis, remove thrombus within the vessels. So we can have a good idea. So the renal artery and renal vein thrombosis tend to occur in the immediate postoperative period. Stenosis develops later on, so greater than 5 to 6 months following transplantation. Complications of biopsy could include, like we said, arteriovenous formation or development of a pseudoaneurysm. So those are complications that we worry about, status post renal biopsy. So renal artery thrombosis, so occurs very in the very early postoperative period. So immediate diagnosis is critical. So thrombectomy or thrombolysis can be performed to prevent the loss of the transplant. It's a very low incidence, less than 1%. More common in living donor transplant recipients. So some causes for renal artery thrombosis could be complex arterial connections. In pediatric patients, due to small sizes, pediatric transplants due to small size of that main renal artery. Patients being hyperacute or in the acute rejection. Hypercoagulable states, if that artery is kinked or bent. Any arterial dissections, vessel size mismatch. Acute tubular necrosis, prolonged ischemic time, and faulty surgical technique could also lead to renal artery thrombosis. So if that renal artery is thrombosed, the patient usually presents with acute anuria. So if you think about it, the whole job of the kidney is to filter the blood, remove the, the pollutants, toxins, and then produce urine to get rid of the waste. So if a patient all of a sudden stops voiding and they're not making any urine, that's a really bad sign. That's a red flag that there could potentially be renal artery thrombosis. Another indication could be tenderness over that graft site. On ultrasound, if the renal artery is thrombosed, the kidney is going to become very enlarged and hypoechoic. And then we might see focal or segmental areas of infarct. So same like splenic infarcts, you get those hypoechoic or anechoic wedge-shaped areas that don't demonstrate any vascularity. So with this renal artery thrombosis, this kidney is not getting any blood flow at all. So that you can see that external iliac artery showing up with color. So this is power Doppler, and then nothing within that kidney. So patient presented with acute pain and no production of urine 1 day postoperatively. Power Doppler revealed complete absence of blood flow to that transplanted kidney. This patient was returned immediately to the operating room following the ultrasound. They performed a thrombectomy for that renal artery, the main renal artery. So although blood flow was restored, the patient developed severe acute tubular necrosis and required dialysis. But thankfully, eventually renal function recovered.
Do they put them on blood thinners when they get kidney transplant?
I am not sure. Not sure. That makes sense, prevent thrombosis. Then you're also worried about post-surgical bleeding, but it's possible. So with renal artery thrombosis, So another case, postoperative baseline Doppler in the recovery room demonstrates no evidence of flow within the parenchyma of the upper pole. And more superior main renal artery could not be identified. The RIs were 0.96, which is very high in the segmental artery in the lower pole. So these findings were all consistent with thrombosis of that main renal artery to the upper pole. That's something I forgot to mention. Some of these renal transplants, some of the surgeons elect to put two main renal arteries so that these transplant kidneys actually have a dual blood supply. So that's just something that you have to assess for and just kind of be cognizant of. So sometimes they'll have a renal artery going, to one feeding the lower pole, another renal artery feeding the upper pole. Unfortunately, that makes kind of double the work for you, but this was showing an area of focal infarct where we got a segment of the kidney where there's no blood flow being perfused to it, where the rest of the kidney is okay. So focal infarct or segmental infarct could be due to embolus within that vessel. So a clot getting lodged into one of these smaller vessels could be due to infection, vasculitis or inflammation of those vessels causing reduced perfusion, scarring due to injury from perfusion catheters, progression of a distal or branch stenosis in the main renal artery, or cellular infiltration of the vessel wall due to rejection. So renal vein thrombosis. So this one's a little more common, about 5% incidence, usually occurs in the first postoperative week. More common for transplants placed in the left iliac fossa. Patients present with abrupt onset of oliguria, graft swelling, and tenderness. Nephrectomy and retransplantation are required if infarct has occurred. So some of the risk factors for this, hypotension, being in a hypocoagulable state, acute rejection. If there's a stenosis at that anastomosis site of the main renal vein, venous compression from any sort of fluid collections outside the actual kidney can cause renal vein thrombosis, or even propagation of an underlying clot in the iliac vein. So with renal vein thrombosis, we also see enlargement of the transplant with decreased echogenicity. That renal vein could appear enlarged. Will document absence of venous flow, again with increased resistance within that main renal artery. So similar to what we saw with the liver transplant, if the hepatic veins are thrombosed and that blood flow is backing up into the liver, we see increased resistive indices in that main renal artery. I'm sorry, the main hepatic artery. We would see the same thing with the kidney. So if the main renal vein is thrombosed, blood flow is going to back up into the transplant kidney itself. And then that pressure is going to build up within the kidney. It's becoming an enlarged, swollen. When we Doppler the main renal artery, we'll see increased resistive indices, and we can even potentially see reversal of flow in that main renal artery. So it'll have a very similar appearance to someone who is either in hyperacute rejection or suffering from severe acute tubular necrosis. So again, just by Doppler, we can't necessarily tell the difference, between those three things. So reversal diastolic flow in the main renal artery can also be seen, like I said, with hyperacute rejection, severe acute tubular necrosis, and compression of the renal parenchyma by surrounding fluid collections. There was a good example. So here we can see the hilum of the kidney, the renal artery flowing into the kidney, and then that main renal vein with intraluminal echoes absence of flow, so this is a thrombosed main renal vein. And then when they Dopplered, it was so high resistance that during diastole, it was enough to even push that blood flow backwards where we got flow reversal during diastole. So that's a very, very high resistant, arterial vessel. Yeah, so that's something that can also be seen not only with renal vein thrombosis, but with acute tubular necrosis, as well as hyperacute rejection. Something I also wanted to mention is that if the kidney is also being compressed by anything, so if there's fluid collection surrounding the kidney and maybe a large hematoma, a large seroma, or anything compressing the actual kidney itself, that also is enough to put stress on the kidney to raise your resistive indices. That's enough to put stress on the kidney to affect your BUN creatinine levels. So kind of think of it as like a subcapsular hematoma. When you see that in the liver, those subcapsular hematomas, they grow, they expand, they compress the liver parenchyma. They put stress on that liver, so it'll affect your liver function, a subcapsular hematoma. So same thing with the kidney here. A good example, or a hematoma in the kidney itself, compressing it would be enough. All right, so our most common now. So renal artery stenosis is the most common vascular complication when we're talking about renal transplants. Occurs in up to 12% incidence. So renal artery stenosis occurs in that period after 3 months, within 3 years of transplantation. More common in the living donors, most commonly at the main renal artery connection. So at the anastomosis site. End-to-end connections have the highest risk for developing renal artery stenosis. Some risk factors that could lead to renal artery stenosis would be a complex arterial connections, pediatric transplants. So if that kidney came from a smaller child, that main renal artery is very small. Since it's a small main renal artery, it's more prone to stenosis. Intimal fibrosis or scarring, poor surgical technique, vessel injury from catheters, allergic reaction to suture material, rejection, and then intrinsic vascular disease. So if a patient has, some of those predisposing risk factors to developing atherosclerosis, so those disease factors will also attack, these transplant kidneys as well. So with renal artery stenosis, patients present with new onset or worsening hypertension. That's one of the things that we look for is that, unmanageable hypertension, medications aren't controlling it. Since these transplant kidneys are fairly superficial, you might be able to hear a brewery over that transplant kidney, indicating a stenotic lesion. The Doppler criteria, we have a much higher threshold when we're talking about transplant kidneys. Typically it's over pieces-stock velocity is over 200 to 250. If it's over 300, this has a very high specificity. And then a velocity ratio greater than 2. With stenosis, we look for all those signs of stenotic lesions, the spectral broadening immediately distal to stenosis, and then the presence of targus parvis waveforms distally in that main renal artery and also within the intrarenal vessels, the intraparenchymal vessels. We can always utilize a non-contrast MRA to confirm. Again, because this patient, has kidney disease, all they have is this transplant, they're not going to do any sort of, contrast imaging that could potentially damage this kidney further. Stenosis may be treated with percutaneous transluminal angioplasty, arterial stenting, so they might do a balloon angioplasty to try and stent balloon open that stenotic area, that narrowed area. They may also decide to put in an arterial stent to try and keep open that artery. Or it might just be a matter of surgical revascularization. So using some sort of graft or surgical procedure to try and reconnect the kidney to a good blood supply. So this we're just showing an area or a picture of severe stenosis for an arterial anastomosis. The bottom transplant showing the velocity of almost 500 centimeters per second. So very, very fast. So patient presented here with severe hypertension, 6 months following a living donor transplant. With color Doppler, we see aliasing in the main renal artery above. The Doppler waveform showed increased velocities of 300 centimeters per second at the main renal artery connection. And then Tardish Parvis waveforms in the segmental artery within the actual kidney itself. So arterial occlusion in the graft. So occlusion or thrombosis of the allograft artery. It's rare, so it's an unusual complication. He said the occlusion occurs in the immediate post-transplant period due to rejection, other technical factors. So arterial and venous flow are absent in that kidney, which would lead to loss of the graft. Just showing some pictures now for transplant infarct. So again, you look for areas that appear hypoechoic, different from the rest of the tissue. Again, typically have that wedge shape appearance. So you see decreased echogenicity there in the lower pole of the kidney. When they put the color on, so that area demonstrated, flow within that area. Infarct. We can also have renal vein stenosis, so a narrowing of the main renal vein. This is usually caused by some sort of extrinsic compression from a fluid collection or perivascular fibrosis, so that vessel becoming fibrotic and narrowed. Ultrasound findings include vessel narrowing with focal aliasing and high velocities in the area of that stenosis. There's no specific criteria that's been established for grading renal vein stenosis, but you could use a velocity ratio for clinical significance. Treatment of choice is to just stent open that vein, try and keep it open. So this was showing an area of focal aliasing at the site where the main renal vein connects with the external iliac. Doppler, the external iliac vein demonstrates a velocity of 15 centimeters per second compared to 200 in the main renal vein. Venous occlusion in the graft. So occlusion and thrombosis of the graft, again, also it's a rare complication. Would happen in the immediate postoperative period. So with this, also the kidney becomes enlarged. The tissue itself starts becoming very heterogeneous. We'll see absent venous flow, that renal artery waveform pattern that consists of sustained flow reversal during diastole. Causes of this could be hypovolemia, surgical or technique difficulties, or even propagation of femoral or iliac DVT into that main renal vein. As well as compression, like I said, from of the vein from fluid collections in that area. All right, so Skip one before biopsy. So arteriovenous fistula. So an AVF or fistula is usually a result of a biopsy procedure. May occur from trauma as well. With any AVF, we see areas of very high velocity, low resistance in that artery. There might be a visible brewery. Marked disturbed flow within that fistula. So what does it look like with ultrasound? So we might see areas where we see very fast turbulent flow within that kidney. Next picture is kind of better. So when we put our color on, we see area that looks like very fast turbulent flow. When we Dopplered it, we're getting velocities that are really off the chart. This indicates, the presence of a fistula. So this was likely due to when they went in, tried to take a biopsy sample with that needle. They punctured an artery, they punctured an adjacent vein, and then created a connection between that adjacent artery and vein, creating a fistula. Arteriovenous malformation. So on 2D, you just see an anechoic area with an echogenic line in between. They thought it could be a septated cyst. When they put their colorful on, they saw it filled with color. Or pseudoaneurysms. So again, pseudoaneurysms, another potential cause or another main cause of a development of pseudoaneurysm, again, is arterial laceration during that renal biopsy. So those pseudoaneurysms on 2D appear as focal anechoic areas. When we put our color on, demonstrates that yin-yang pattern. The neck of the pseudoaneurysms has that characteristic bidirectional to and fro flow. So again, these look like pseudoaneurysms, again, regardless of where they are, have these same characteristics. That yin-yang flow pattern, neck of the pseudoaneurysm demonstrating that bidirectional flow. This is a larger pseudoaneurysm.
It's just coming off the renal artery.
Probably main renal artery by the hilum. Yep. They're intrarenal pseudoaneurysms. Extrarenal arteriovenous fistulas or pseudoaneurysms, usually due to faulty surgical technique or breakdown of that connection site, or even from infection. So they require intervention due to their larger size and risk for rupture. So something that could potentially occur, but is very rare, is actually torsion of the kidney itself. So similar to ovarian torsion, this kidney could turn on that vascular pedicle and actually torch the kidney. So this can occur in the early postoperative period. So it occurs when the transplant kidney is placed in the peritoneal cavity, or when the main renal artery and the left and the main renal vein are excessively long or redundant. So this torsion could be partial, could be complete torsion. These have non-specific clinical signs, but may include abdominal tenderness and swelling. So early diagnosis of this is very important to improve the blood flow. So ultrasound findings might include malrotation of the kidney, hydronephrosis due to twisting off and pinching of that ureter, leading to hydronephrosis, thickening of the uroepithelium, are normal to reversal of arterial diastolic flow. So fluid collections. So we said that some of these fluid collections, can potentially compress the kidney itself, could compress the vessels, particularly the veins. So we can have hematomas, which is a collection of blood, seroma, collection of serous fluid. So seromas are typically just anechoic in nature. So if you see a seroma, it's usually just very anechoic. Hematomas will have intraluminal echoes, particularly depending on the age of that hematoma. As it starts to clot off, it becomes very echogenic. You might see areas that are more fluid and more solid, depending on if that patient, been laying there for a while. Abscess or collections of pus that have obvious borders to them. Uroma, collection of urine, or lymphocyte, a cyst that contains lymph. So hematomas, they can occur postoperatively following biopsy or pelvic trauma.
Thank you.
Yeah. Subcapsular hematomas may compress the actual renal parenchyma. So we said that when you have compression of the tissue, it causes renal dysfunction, could lead to ischemia. This might require aspiration or surgical debridement of that hematoma. An entire kidney being compressed by surrounding hematoma may result in a condition referred to as page kidney. Acute hematoma are usually echogenic, becoming more anechoic and complex over time. Hematoma should be non-vascular, so there should be no active flow within that hematoma. So that baseline study performed in the recovery room is done. A large complex lobular echogenic fluid collection, medial and inferior to transplant kidney is noted. Most perinephric collections identified immediately postoperatively will become hematomas. This large hematoma adjacent to the vascular pedicle was observed to grow during the course of the ultrasound examination, and the patient was returned to the operating room to evacuate the hematoma and to tie off the bleeding vessel. So this is showing a subcapsular hematoma. So here you can see the actual borders of that subcapsular hematoma and how it actually is compressing now that renal parenchyma. So the page kidney, so with this condition, hypertension that develops following long-standing compression of that renal parenchyma by a fluid collection like a hematoma, seroma, or uroma. So that compression causes decreased blood flow, which can trigger renin secretion that leads to hypertension. So in this case, we're seeing A is a sagittal and transverse oblique in B, demonstrating the complex fluid collections surrounding the kidney and distorting the renal parenchyma in A. So in B, there's a fluid level that's noted. These findings are consistent with the large subcapsular hematoma compressing the renal parenchyma. So because again, that kidney is being compressed, it's under a lot of stress now. That's gonna alter your arterial flow patterns. So instead of having a nice low resistant flow pattern to this kidney, because of that hematoma, we have very high resistant flow. This was intrarenal, and then also Dopplering further out in the main renal artery. So despite surgical decompression of this hematoma, the patient developed severe acute tubular necrosis. And the kidney never regained function and had to be removed.
Say how long, like, For it to be removed, or is it just the indication that you have that they just remove it right away? Or is this above the pay?
I mean, they're gonna try and see if they can get this kidney to recover. I mean, I guess they would essentially wait till it completely dies. I mean, they're gonna put them on dialysis definitely to take the stress off the kidney to give it, so it doesn't have to work. You know, yeah, work as much, so. Perinephric abscess, so it appears as a complex fluid collection. With low level echoes, so with abscesses, you may also see some peripheral vascularity to that, area or lesion. So diagnosis confirmed with aspiration and then running cultures on those aspirations. A uroma. We said this is an encapsulated collection of urine. So this is also an uncommon postoperative complication. Maybe due to extravasation of urine from the calyces, the renal pelvis, the ureter, or that ureteroneocystostomy. Patients present with abdominal pain, tenderness, decreased urine output. There might be discharge from the womb. Uromas appear as a well-defined anechoic fluid collection, particularly found between the graft and the bladder. Interval increase in size of the anechoic collections is suggested by a uroma. Lymphoceles. So this is a collection of lymphatic fluid caused by iatrogenic disruption of the lymphatic vessels. So this could develop, 4 to 8 weeks after surgery. This one has a fairly high prevalence of up to 20%. May appear as anechoic or anechoic error with internal septations. These can compress the ureter, the vascular vessels, pedicle, resulting in hydronephrosis or increased velocities in the main renal vein or artery. We're showing some large lymphoceles now. So large anterior lymphocele and septated lymphocele posterior to the kidney. Infection and neoplasm. So infection is a common complication due to surgery and immunosuppression. Cytomegalovirus is a common pathogen and infection that may present as pyelonephritis. So with pyelonephritis, these may cause diffuse or focal areas of either increased or decreased echogenicity. Segmental infarct may cause similar focal appearance, so just keep that in mind. Segmental infarct is also more sharply marginated and wedge-shaped and avascular. Renal transplant recipients have increased risks for developing cancers due to those immunosuppressants. So some of those common cancers are lymphoma, as well as skin cancers due to those prolonged immunosuppressant medications that they're on. Other cancers such as rectal or cervical carcinoma and renal cellular carcinoma in either the native or transplanted kidneys have also have increased frequencies, as well as development of that post-transplant lymphoproliferative disorder. So we saw that in the liver transplant patients. It also presents itself in renal transplant patients as well. So this affects about the post-transplant lymphoproliferative disorder, affects about 2% of transplant patients. Commonly affects the tonsils, cervical lymph nodes, the lungs, solid and hollow abdominal viscera, and the lymphatic systems. So these appear as a focal mass of homogeneous echogenicity. Symptoms can range from flu-like symptoms to high-grade solid lymphoma. early, post-transplant lymphoproliferative disorder tend to affect young patients within the first year. Patients do well with antiviral therapy and decreased levels of immunosuppressant. Late onset is more aggressive with poor prognosis. Usually presents greater than 2.5 years after transplant. Ultrasound findings, we'd see a diffuse solid parenchymal renal mass, diffuse parenchymal infiltration, perihilar lymphadenopathy that compress and engage the ureter and the vascular pedicle. So this was that lymphoproliferative disorder. So here you have your kidney tissue and then that large mass. So it's slightly heterogeneous, a predominantly solid mass. More pictures of that post-transplant lymphoproliferative disorder. So you can see that solid mass, pretty homogeneous. Hypoechoic.
Wait, and this is caused by,
The fact that these patients are on immunosuppressive therapy, they develop this condition. So it's similar to the one that we saw with the liver transplant. So it looked pretty similar to hepatocellular carcinoma in the HCC, this condition. So this can also develop with kidneys, the kidney transplants. It's the same type, same lesion. It could show other places as well within the body. So I mean, if they see this in the kidney, they'll get a full workup to see if it's anywhere else as well. Again, because of those immunosuppressants, they also run the risk of also developing renal cellular carcinoma as well. There's a transplant kidney showing a heterogeneous, more echogenic mass in the upper pole. Ureteral obstruction now. So this can occur typically in less than 5% of renal transplant patients, usually within the first 6 months. The vast majority of the narrowing or strictures occur within the distal third of that ureter. Most frequently at that UVJ where the ureter connects to the bladder. And are due to ischemia or poor surgical technique. We can also, again, like I said, get compression of the ureter from outside fluid collections, pressing on the ureter, stricture from ischemia or rejection, and then intraluminal obstruction of the collecting system from either blood clots, stones, calculi, fungus balls, or even papillary necrosis.
Fungus balls, where would that come from?
I have fungus balls in here. I think I had it on the peds lecture.
That's nasty. Like where? How was that introduced? For surgical sterility? Like,
I don't know, dirty,
Mold of him from the house.
Maddie got this with a biopsy, didn't you? Or that, yeah. Okay, well,
is he scanned it?
yeah, well, yeah, but I just worked in machine doctor.
what kind of
I
biopsy?
think everyone with the system fire one.
Just thyroid. It's all right.
Yeah, Dana was dropping shit, and she's like, don't you work in where you start dropping it. I was like, okay. So I.
Yeah, fungus balls, I mean, they'll look like these. Echogenic, like little balls that they don't shadow really. It's not like a calcification.
I'm gonna start putting that on report.
The
I
fungus
couldn't
ball.
get, I couldn't get the shadow, so. it's
Question
definitely a
mark, fungus ball, question mark.
So you see it with like pyelonephritis or, like dilated calyces, like that's when you'd really just kind of notice it. That's the only time I've ever really seen them.
You have seen it?
Yeah, and a kid.
What? But. Why?
Where does it come from? Fungus.
Fungus.
It's like all these, like, it was like a bunch of like,
You eat too much mushrooms. That uses toes. Oh my god.
this is in the bladder. Oh my God, that's crazy.
This is getting more disgusting.
Yeah. Yeah, it's pretty bad.
Not stick.
Oh, yeah.
Um, yeah, we're almost done. All this stuff you guys have seen now from this point. So with the transplant, we could also wind up with hemorrhage within the collecting system. So development of blood, within the collecting system, so blood's gonna look, very, I don't wanna say heterogeneous, but like. You can wind up with blood, you can also see blood in the bladder as well. So that's a big bladder that's full of hemorrhage. See the Foley catheter that's inflated. And then you can still see the bladder, the borders of that bladder filled with blood. So you got all those intraluminal echoes within there, the layering. So that's one thing, with the blood, you see layering typically. So that bladder needs to get irrigated and cleaned out.
Just take the water.
I've seen that, like, when they irrigate it, they basically do reverse, like, Foley, like, so they're hooked up to a big bag of fluid and they're just pumping the bladder full of blood to just kind of flush all that out.
What?
So like, they'll fill it with water and fluid and they'll slowly try and just break this up and
Oh.
drain it out, and they could do
You just said that They
suction.
put more blood in it.
No, they fill it
What?
with, they fill it with fluid. So they
What
like,
makes
through the
sense.
Foley catheter, they then fill the bladder with fluid and irrigate it. It's gross how much comes out.
Do they pee it out or it comes out of the catheter?
Out
Another
of a catheter, out of that same catheter, they'll fill it with fluid and they'll just kind of repeat the process, trying to like irrigate it.
Like,
How does all this blood get in there?
no. I'm talking about with the catheter. So with one catheter, you're pumping something in this catheter. And then the catheter's taking it back in.
So they'll fill the
Okay.
bladder with fluid and then they can suction it, like pull it out. Like there's a valve on usually.
Oh, yeah, it's reverse, right?
Yeah,
Or whatever.
yeah.
Disgusting. Go ahead. Car smells. Yeah.
Renal calculi, so we want to assess the kidneys for renal calculi as well. So stones could be non-obstructing, so if you see stones, out in the cortex, or in the actual collecting system, and these could be non-obstructing, they're usually asymptomatic.
Sure are.
You have them? Or-
No, I don't have them. People just feel like, I don't feel any symptoms, and it's all of a sudden it's like,
They
Um,
don't demonstrate
Wow.
clinical artifact today, because I was scanning on, one of the sites. And we see it, and it looked like, that's what we called it, an echogenic foci, because it didn't have any of the characteristics of the stone, it didn't have a twinkle, and it didn't have like the shot, like there wasn't a distinctive shadow. Yeah.
Um, So Yes, not all stones will twinkle. If you wanna really try and get it to twinkle, just really optimize it, make your box very, very small.
The twinkle setting.
Do they have that?
Some machines have it.
Do they? Oh,
Yeah.
that's cool. If you're ever not sure, you could take your pulse wave Doppler and put it over it. And if you get a momentary period of very loud static, that's just like,
Yeah.
that's twinkle artifact, like if it comes in and out. So like, if you get that artifact, like if you're on it and it comes, if the breathing's coming in and out, moving, like, is it twinkling? I'm not really sure, like, like you could always do your pulse wave Doppler, and if you get that crazy sound, like it's cause it's off the chart. Like it's just like it. And it fills it'll fill your whole spectral tracing with just static.
Yeah.
Like if you do that, you've proved it's twinkle artifact, it's real.
Why? Because it's so like that.
Yeah, it's like so just in such an
Yeah.
intense reflector, yeah. So that's one way that you could like say, like prove that it's real twinkle artifact. What?
No.
Simu loop it?
No, it's just, sometimes that would have probably came in handy. A
Yeah.
couple times.
Yeah.
Instead.
Just saying. The more you know. Renal calculi. So for my exam, you guys need to be able to recognize renal calculi, recognize,
Will it have a twinkle?
it'll be a very obvious kidney stone.
Because it could also be a fungus ball.
Yeah.
Now that we know that they're fungus balls.
So have you guys seen porcelain gallbladder?
I'm sorry, what?
Or, well, not porcelain gallbladder, do you guys know what the west sign is? West sign,
Yeah,
wall echo shadow
yes,
with gallbladder,
yes,
it can happen with kidney too.
lovely. Fantastic.
Fantastic, cortical nephrocalcinosis.
Why can't they just say west side, nephro west
The left
side?
kidney shows
Yeah.
complete dense shadowing and non-visible renal tissue. So a rare disorder in which there's too much calcium deposit within the kidney. So in a renal transplant, this would be associated with a chronic rejection. So if you, again,
It says-
shadows, you should be very cognizant of when you're scanning ultrasound. If something is shadowing like this, why is it shadowing?
No.
So yeah, so I always remember this as kind of like the west sign for kidney, this cortical nephrocalcinosis.
I couldn't find a gallbladder one time, a couple semesters ago. I could not find a
Oh,
gallbladder and I went out and I got
remember this.
Dana, I'm like, I got everything, I cannot find a gallbladder, and she's like, it's right there. I'm like, what do you mean it's right there? She's like, it's right there, and I couldn't see because it was so shadowed out because it was completely
It's all
full.
full stones.
And she was like, it's right in your image, and I was just like, Dana,
I'm a
she was
first
like-
year student.
She's like, you can't see it doesn't look like the gallbladder
No.
you're familiar with because it's full of stones. Like, oh,
Hello?
that's fun.
No, bitch, I don't.
There's, the one, I think it's team effective sludge or something like that, I was reading about, where it's like so filled with sludge that it looks isotope to the liver. I've seen that too,
Wow.
like it
Don't you be
literally,
able to see the,
you can
um,
kind of see the wall,
yeah.
but like, as far as if you're, looking for the gallbladder itself, like I feel like it's good.
Son wakes
information
up,
to
this
have.
Danny wakes up this morning, he's like, I'm hurting, Dad. I'm like, what do you mean? He's like, "Oh, it just kind of hurts, like,
Oh no, does he have a hernia?
I don't know, like it's testicle, like it's right testicle.
Oh.
He's not like an acute pain, so I'm like, it's probably not torsion, like, I mean, maybe a torsion appendix testing, could be. Maybe
Did you just
epididymitis,
bring
I
him
don't
in
know.
here to scan him?
My wife's taking him to the doctor, I mean, it's gonna wind up with the ultrasound anyway, but like,
Yeah, but at least if you scan him, you can know.
I would know, yeah, maybe.
You'd probably do a better job. Well, where'd you take him?
right now, I think just like his
That
pediatrician.
just looks like another piece of liver. That's insane.
What is it?
Sure, the MSC one's just.
I think.
Are you all right, Cassie?
Oh, yeah.
Oh, okay.
I don't think you were sick. I thought you were like not feeling well. I mean.
I didn't mean emotionally. We're all sick emotionally. It's bad.
Hydronephrosis, so you guys all know hydro.
Yeah, skip.
Skip.
Great. Complication of renal collecting system, yep.
Yep, so we said in transplants, some mild hydro can be fairly common. Sometimes it just persists indefinitely with these transplant kidneys. A lot of it has to do with like the fact that you have a much smaller ureter now connecting to the dome of the bladder, so as the bladder fills, you get a little bit of retrograde flow of that ureter, back to the transplant kidney. When it's moderate or severe, then we worry about, that when we're talking about our transplant kidneys. I want you guys to be able to recognize a picture of hydronephrosis, which you hopefully
Yep.
should. So just also recognize, again, hydronephrosis can also affect your resistive indices. Hydronephrosis will definitely affect your BUN and creatinine levels. So this kidney's under stress. The hydronephrosis will raise your resistive indices. So just comparing right and left. So the right kidney had an RI of 0.76. The left kidney, which had no hydronephrosis, was 0.6. It's just showing, again, some different stages of hydronephrosis, going from mild to more moderate and then all the way out to severe.
See, I would be like, oh, that's a food.
Oh, that one? Yeah, be careful. Especially if you see something central like that, cystic structure right in the middle,
It's usually hydro,
could be, yeah.
yeah. That's what I've learned.
Again, hydronephrosis, since it's urine, but with color, so you can differentiate, between hydronephrosis versus a prominent renal vein. This is, very severe hydronephrosis where you get complete, obliteration of the renal parenchyma all the way out. So this is a good example of hydronephrosis versus a prominent renal vein. So on 2D, that looks like hydro. I would dupe me, but you put your color flow on and it fills with color. So when we're doing assessments for the kidneys, intravenous contrast agents can be used. Because our contrast agents are non-nephrotoxic.
No, we're just never.
Yep, so it's just gas bubbles, so it won't damage the kidneys.
You just got gassy kidneys.
See your profile. I'm working on it. Erase my pictures. Did you erase them? Yeah, like two of them didn't show up. There's only so many, like. Now I'm kind of interested.
It feels amazing.
Cover all these.
It's like, I literally have no product in it, and I just like, I'm playing in my hair. It feels so good.
That's how it's weird. Yeah, your profile's fire. But like, it's significant weight off my head. but-
Yes.
Oh my god, if I can take my hair out. And I'm kind of like. Not like nice to like,
Yeah.
like my hair, but it's just like. And it's like a different feel because like the stuff that you move, it's just like.
Yeah, I need like a good, scalp scrubber, so I looked into that.
Like my
So
photo.
I have scalp
Wow.
cirrhosis.
Okay.
I'm sorry, not cirrhosis.
You like.
My friend calls it cirrhosis.
Yeah.
Cirrhosis in our fucking stomach.
Eczema. Okay.
Like scalp.
Immediately
or
now.
something.
Okay. Immediately now. We don't know how to finish.
Nice person, that makes me feel like you're not a nice person.
So all these treatments that I've been doing, like,
It's really, really
help, but then it just comes right back.
good question.
I gotta say mulch.
It's definitely not that one, but anyway, figure it out. So it's all ever. Oh, absolutely.
How you holding up, Des?
Oh, what are you doing?
Got Desiree on Zoom.
Oh, I was like, what?
I was like, who are you talking to?
Yeah.
I'm playing to the audience.
Okay,
Alright.
I think that's when he started.
Oh, okay.
Like, you know what I mean?
Yeah.
Which one?
Well, child.
What is it called? My hair fake, I just.
Alright, so kidneys.
Yay.
Yay, kidneys. So these are just some different renal variations in anatomy. Something you might encounter a horseshoe kidney.
Yeah.
Where the two kidneys are connected by an isthmus of renal tissue.
Upside down.
Kind of, yeah, an upside down back.
He just changed his face.
He's like, oh my god, it is.
Cake kidney. So a fusion of two kidneys with a double collecting system. Pelvic kidneys, so those can be kind of common, fairly common. So again, if you're scanning normally, you don't see a kidney where it should be, go check the pelvis. It's the most likely place you'll find it.
Yeah.
Yeah,
I feel like we're familiar with these, but I just like in my head. Where would a cake kidney sit? Like, you know what I mean? Like, I think midline, would it be more to the right or the, you know what I mean? I feel like
Compared to the air. and
honestly,
everything.
like with the horseshoe, I know they're kind of conjoined, like. It's almost like midline that you know, because I've seen one at Nemours, but I wonder how that would look or where to expect. A cake
So-
Pancake kidney, what is going on?
Do they add ham to the cake? Kidney, and then we have a,
If you have a heart.
see, not to be confused with the crepe kidney, which, no. I'm just kidding.
Waffle.
Waffle kidney. Yeah, Waffle House. Yeah, I'm there with my bougie crepes and she's going waffle.
I mean, honestly, I probably would be more waffle and crepes.
I am a waffle, yeah.
More Waffle House than
Waffle House.
upscale.
I'd go to Waffle House before an IHOP.
Yeah.
IHOP has lost its like.
I went into the one in
Depends on the
Newcastle
times.
one time and it smelled like vomit and so
Waffle
I
House?
never went back. No, no,
IHOP.
IHOP.
Yeah, I'd rather go to Waffle House than IHOP.
So that answers your question for the cake kidney. It would be down here. This is where they form embryologically, so there's less going on. And they're fused together, so like, you know, again, they would form right and left and then migrate to where they sit.
If someone has a dual arteries going into their kidneys, is it normal that it's bilateral or is that just, can that just be, or is it like normally just one-sided variant?
Yeah,
It could be
it doesn't
bilateral.
have to be bilateral. It could just be a one-side thing.
I mean, but is it normally bilateral? If you have it on one side, you have it on the other, just anatomical variant?
I'm not sure.
Okay.
Do you encounter that?
Yeah, yesterday at the bath lab, there was,
That's crazy.
it was the
On both
guy, she
sides?
was scanning him and she was like, cause they were down 2 people.
Okay,
And they had all these patients, it was just insane. And she was just like, of course he has a duplicated artery on the left, she was scanning the left side. And then she went to scan the right side, she's like, and of course it's over here too.
Oh,
She's
man.
like, it's just double the work.
it
Was
is.
that MJ?
No, it was Ashley.
Oh,
Pregnant.
oh.
It's a good pickup though.
Yeah.
What?
She was really nice. She was just really hungry.
Okay, I bet she was.
Yeah.
She was just really hungry. I don't think I met this one.
What? No, I just. I'm not like fond of her.
No, she
No.
was really nice yesterday.
I
They
bet
all
she
were,
was.
except the only one that wasn't was Erica, and it wasn't that she wasn't nice, it was just that she was just, didn't talk to me.
This is morning crew, night crew, like you could see it, you can all see it. It's okay.
You're gonna cross the divide.
Exactly, like I'm literally the mid.
Like,
Like, think the whole world. Can only take some of you for a few hours and some of you for a few hours. That's it.
What they gave color.
Huh?
I said what they gave color.
Color. Well, according to Cheryl, it's medial, but you know, whatever.
Yes, she does.
Yo, Cheryl with her medial color.
Yeah.
I'm like, Cheryl, stop.
I mean, maybe she's right, but like, that's how we're taught, so what do you want me to do? I just do whatever the text is.
Girl, I just put last dash medial. This is what you're gonna get, Cheryl. I don't
Well,
care.
make sure if you go to Smyrna, you do upper pole, mid pole, lower pole for both.
Never go to Smyrna. Go to
Well, you
Springfield
can't now
tomorrow,
anyway,
though.
because
I've gotten
she's
to that point.
training a Middletown person.
Yeah, apparently I'm not allowed to go with you tomorrow.
What?
So what are you doing? Are you
I'm
going to
going to
that?
Dawn tomorrow. Email Dawn. Hey, girl.
Oh,
Can I come with you tomorrow? I mean, I was like, I don't care, but she was like,
you guys are gonna get us kicked out of college.
she was like, there might be 2 texts there tomorrow.
What are these?
Sis.
Yep.
What are these? Sis. Sis.
That's polycystic.
I know, right?
There you go.
What is that chick? So,
We're ready for the board.
You ready for your report?
this is
Yeah.
fantastic.
I mean, if it was just like this, I could totally pass it. This
What's that?
looks like dilated.
What the hell is that? Renal pyramids?
No.
That just dilating?
Is that air?
Renal pyramids.
Pneumobilia?
That broke out.
Is it pneumobilia? Is the right bottom one?
Mobilia.
I would see a staghorn kidney.
Oh my god.
Staghorn calculus.
Yeah.
I mean, that's just like big gnarly.
Why?
Some of those might be like this. This guy might be. I'm only clipping like a side of it.
There's always, I feel like kidneys always have stuff in them that I'm like, that looks like a stone, like it'll be like bright and white, and then I'll put like color on it and it won't twinkle, and I'm just like. But it's not, I mean,
Yeah.
it's just part of the kidney, but like, I feel like you think,
Yeah,
and then like, people will measure stuff that I'm just like, that's.
Yeah,
Okay,
I
I see
agree with
it
you.
now, but like, it's weird.
kidneys. A lot of times like vessels could become calcified within the
Yes.
kidney. And they could look like stones. It's just
Oh my
calcified
god,
vessels.
so many times I'm like, oh, that's a stone, no, that's not a calcified vessel, and I'd be like, okay, so I'm like, all right, this is a calcified vessel, no, that's a stone. You know what? I don't care anymore.
You just have to flip a coin.
Literally.
So I feel like I had that issue. Do they look exactly the same? Well, I guess they would. And like my favorite thing, I'm like, if I can't turn on it.
Yeah.
The other.
Yeah. So what was that last one? Nephrocalcinosis?
These are, yeah, this is
Or
just,
were you just looking to
nephrocal.
say those are pyramids?
Oh, okay.
Really?
Yeah.
Were we even looking for this answer for?
Nothing, yeah,
Okay,
it's just,
great.
yeah, don't
It's
worry
a
about it.
kidney.
Stones, hydro, cysts.
Is it left or right? All right. Kidney.
Are done.
Would you ever want
May I have that, packet, please?
Yes. 1 second, I got something to stop it.
Go with him.
Yeah.
see that person there.
Yeah.
Last night, right,
I'm doing, yeah.
Oh,
No, I'm just asking.
Here you go, here you go.
Ow!
I'll go.
Yeah, with all these boys I know.
Yes. It's in the drawer. I found them when I was getting my gum.
Like, I saw you on Hinge, what you have? Alright, here it is. Des, are you still here?
This isn't.
I don't know if she's.
Okay, I guess.
Well, his hair back when he was born.
Happy son, happy son.